This editorially independent podcast is supported by Astellas Pharma.
Hello and welcome to New Retina Radio, GA Options in Clinical Therapy. This is going to be a two-part mini-series on New Retina Radio, and today I am happy to be joined by Dr. Esther Kim from Orange County Retina. Hello, Esther.
Hey, John. It's great to be here with you.
And our second guest is going to be my good friend and partner from Retina Associates of Kentucky, Dr. Miguel Busquets. Miguel, I just saw you today in clinic, but it's great to see you again here.
Good to see you, John. Thanks. I'm very happy to be here.
Well, listen, we're going to take a close look with Esther and Miguel at clinical practice dynamics, focusing mainly on geographic atrophy therapy. Miguel, I'll start with you. You know, we're about the same age, and we both kind of got into this before we had treatments for wet macular degeneration that could restore vision, you know, really game changers. How does the advent of actually having therapies for geographic atrophy compare to the early treatments for wet AMD and advancing into anti-VEGF therapy?
Yeah, no, this is a transformative therapeutic change that we're going through right now, and it is very similar to what we saw in the early days of treatment for wet AMD, which was also a transformational change. But at the time, what we had early on was PDT, or photodynamic therapy, where we really could just slow down the progression of the condition and make the outcome less bad. So, that was the standard at the time, but it was better than what we had before. And then when we started doing intravitreal injections early on, we were dealing with Macugen, which was an intravitreal agent as well, but had similar results to PDT. And really what we were doing was just controlling the condition and slowing it down. So that's very similar to what we're seeing today with GA. And as a first-in-class, therapy with what we're seeing with the current agents today, we're facing a very similar paradigm where patients we know they're getting worse without treatment, but we now finally have something to offer them, albeit something that might be limited in its efficacy and outcome, but something that can slow down the condition, which offers patients hope. It's a starting point. It's something that we can offer patients. And as I'm sure we'll talk about today, patient selection is also very important, as it was, 20 years ago.
Yeah, I didn't have any reference back then for just how impactful PDT was, and certainly no perspective on how fast we would get anti-VEGF therapy. And just for relevance sake, PDT was approved in 1999, started being used really in mid-1999, full swing by 2000, 2001, mainly for predominantly classic lesions. So there were some limitations, with who you could treat. And then all of a sudden in 2004, really, we started to hit mainstream with anti-VEGF therapy with Macugen. And then it was just 2005 before we had bevacizumab. And we actually could make people better. And I can still remember treating patients with PDT in 2003 and limiting the size of their choroidal vascular membrane. And then not more than 6 months later, we actually had anti-VEGF therapy available. And we were actually able to improve some of those patients' vision. So think about the patients that we didn't give up on early on that we had an opportunity to treat.
Yeah, definitely. I think that's important to think about, because we may be setting the stage today for what that next generation of therapies is. And a lot of these patients may indeed benefit from that down the road and are going to be starting from an advantageous position if we have treated them and controlled the process in the interim.
Definitely, I kind of see it as it's not the beginning of the end, but rather the end of the beginning, right? We have a start, there is actual treatment. So that's kind of where the excitement with these agents lie.
I like that. That's a great way to think about it. Esther, when you have a patient that's either referred in for geographic atrophy or a patient that's already in your practice with geographic atrophy, where do you start with those patients?
Yeah, great question, John. It really depends. I think it's important to frame the conversation differently based on the patient. So I think the initial wave of GA patients was really coming from my existing patient population, especially those with concomitant wet AMD who are being treated regularly with anti-VEGF injections, but were still losing vision. To me, those were kind of the first wave of patients that I was treating. That was actually a very easy conversation because those patients were used to the idea of intravitreal injections coming in regularly. and knowing that their disease was being controlled, but frustrated by the fact that they were losing vision. So they could experience it firsthand that there was a problem that wasn't being adequately addressed. And so that was very easy to get those patients on board. I think now we're starting to see a sort of second wave of patients where now the word is getting out among general ophthalmologists, optometrists who are being more educated about GA and are able to pick up on the disease and refer de novo patients who had never previously been identified as having GA. That is a whole different ballgame, I've come to find, because many of these patients come in 2020, 2025, and you really have to do sort of a relationship building before sort of being doom and gloom, the sky is falling, like you're going to go blind in, 2 to 5 years, and then it's really hard to sort of reclaim that narrative. So I think the conversation is really tailored on that patient and the relationship that you have and their sort of understanding of their disease going in.
Esther, how do you utilize imaging to help explain this process to patients and really kind of show them where their disease is at and what their future may look like?
Yeah, absolutely. So, especially for those patients that don't have central foveal involving disease, the imaging is really critical because a picture says 1,000 words. You can say it till you're blue in the face that you have these potholes in the vision using descriptive terminology. But I think when the patient sees either the infrared imaging accompanying an OCT or that autofluorescence, it's like immediate. It registers. They're able to say, yep, I have the disease and I'm on board. So that imaging, I think, is really helpful for that educational component.
And then once you've seen that patient, you've diagnosed them with the geographic atrophy, how do you move into that point of discussing therapy with the patient?
So once they've established there's a problem, I want to spin it and always be positive. So I'll say, hey, great news. There was never treatment before, but as of the last 1.5 years, we have not one, but 2 FDA-approved treatments. So I will mention that there are new agents that have been proven to slow down the progression of the disease. I make it clear that these are not meant to reverse the damage that's been done or bring back any vision that's been lost, but it is meant to slow down the disease. I'll give the analogy of it's like a train is coming. Instead of it coming at 100 miles per hour, we're able to slow it down to 60, miles per hour, for example. And that obviously depends on the duration of treatment and or the therapy. But I think that visual helps patients understand that a little bit better.
Do you think, Esther, that patients understand data when you're talking about slowing progression and things like that? Is it worth having that conversation with patients about the rate of reduction and potentially any visual acuity benefits or lack thereof?
Yeah, I used to get in the weeds. Like I used to get into numbers and percentages, but it's interesting how my conversations evolved over time. I think if I have that engineer or I have that person who's really done their research and asking me these specific questions, then absolutely I'll give them those percentages. But otherwise, I kind of paint sort of broad brushstrokes, and then I'll give them the patient education materials, which the companies provide and is very useful. And there they can refer to it. They can look at those numbers themselves, have that conversation with their loved ones, because frankly, they may not remember. But sometimes ballpark, I'll say, hey, 20% reduction, potentially 30% reduction, in the future, maybe 40% reduction, especially if that's foveal involving or non-foveal involving. But it depends on the patient, basically.
That's great. Listen, we're going to take a brief break here. In the second half of this, we're going to come back and talk about some of the controversies in treating patients with geographic atrophy and hear from both Esther and Miguel about some of the benefits of treatment, why some physicians are hesitant to treat patients with GA therapy. So stay tuned after this break. We'll be right back.
This editorially independent podcast is supported by Astellas Pharma.
Welcome back to New Retina Radio, GA Options in Clinical Therapy. Once again, I'm joined by Doctors Esther Kim and Dr. Miguel Busquets. Thanks, guys, for coming back. Miguel, I want to come to you now for a really kind of an interesting and controversial question, which is, there are a lot of doctors who have embraced GA therapy, but last I heard, maybe half of retina physicians actually are not implementing GA therapy into their practice. What do you think's holding those doctors back, Miguel?
Yeah, I think there's a few reasons. I mean, I think that the main reason is that this is very much like counseling patients that have glaucoma, in that we're trying to warn them of impending doom. But there's, a lot of them don't even realize that, a lot of the patients don't even realize that there's a problem at the moment. So it's a little bit of a different conversation than we as retina specialists are used to, and frankly, than our clinic flows are used to. Comparing this to what we have with wet AMD, for example, and exudative disease in general, where a patient is suffering from a problem and we're saying, you have this problem, they know they have it, we're going to treat it, and we're, 70% of the time we're going to make it better. In this situation, somebody who might not even know they have a problem has been referred in, and it's a much more extensive conversation. And retina clinic flows are what they are, and having that more elaborate conversation about impending doom is just something that's a little more difficult to have. There's also a dearth of visual acuity data. We have pretty good data on lesion growth and lesion size and arresting the process or slowing it down, but really none of the approved drugs have significant visual function or acuity data, short of some microperimetry data with Syfovre. So that's also makes the conversation a little more difficult. There's a recent vitamin study that shows that AREDS2 vitamins alone and an AREDS2 post-hoc analysis do provide some benefits to patients regarding extension of atrophic lesions into the fovea. So, that's easier than doing a shot. And last but not least, with the class of drugs, we had the initial concerns and scares with the vasculitis that we saw with Syfovre. That's kind of leveled off at about a 1 in 4,000 rate, which is extremely rare, but it did, cause some fear because of the severity of the consequences of that condition. So I think those things combined are probably what are impacting physicians' decisions to stay away from using this class of drugs.
So, Miguel, let me flip that on you then and say, okay, so why do you choose to treat your patients with GA therapy?
Yeah, I mean, I do think that the data that we have is convincing. We do have data that suggests that the lesion growth is controlled, lesion size is controlled by this. We're saving, hundreds of thousands of cones in the macula over time, and that has been shown numerically when we implement these treatments. And we're controlling, blind spot slash scotoma size for these patients, and therefore impacting their long-term functionality. So I do believe that even if we look at the fact that vitamins may provide a benefit, that there is an incremental benefit from using the anti-complement drugs. Now, again, we need to be sure that we're using this in the right patients, and that we're selecting people who are motivated and who meet certain criteria that suggest that they are going to benefit from this, in the sense that we're going to be avoiding problems. For example, proximity to the fovea, size of the lesion, or 2 examples of things that we have to consider.
Esther, we have 2 treatments for geographic atrophy. We have Syfovre, approved over a year ago, has been in widespread use, and Izervay, approved, I think, just under a year ago, and also being widely adopted. What are some of the differences that you perceive and you discuss with patients about these 2 drugs? How do you help a patient decide? What are some of the factors that kind of motivate patients to choose one drug over the other?
Yeah, I would say this is a more nuanced conversation. So, unlike intravitreal injections that we're more used to in the anti-VEGF space, where often our firsthand experience may even trump that of the clinical trial data, with GA drugs, we're really relying heavily, if not entirely, on the clinical trial data. So, as a result, I will lean heavily on the clinical trial data when informing patients. I will usually say up front that there are 2 FDA-approved treatments, and depending on the patient, getting into the percentages, specifically as pertinent to foveal versus non-foveal involving, and then, of course, the potential side effects, those akin to any intravitreal injection and those more related to these particular medications, specifically with Syfovre is associated with vasculitis. And then there's also the risk of IOI or ischemic optic neuropathy. So when I'm looking at a patient, insurance, is going to realistically dictate a lot of things, but all things being equal, I'll look at the risk factors of the patient, be it NAION risk factors or a history of like uveitis, those kind of factors. And ultimately, I think I end up making the decision. I'll kind of make a recommendation at the end of the day because, patients are generally like, whatever you say, doc, you're the expert, right? It's very, very rare that I've had a patient ask me for a particular medication, in which case I will often just acquiesce because, if there's no particular contraindication for that. But that's generally how I decide. And then I love to provide the educational information. Both companies have really great videos out now, so that's been an adjunct to my armamentarium of patient education.
Yeah, I agree. It's one of those things where it's hard to know how far down into the weeds to get with the nuances around the two different drugs. My personal take is that I feel like Syfovre has very robust data. I mean, Apellis has done a really bang up job at analyzing data and providing things like Miguel alluded to with microperimetry data and other things such as that. They had broader inclusion criteria, including subfoveal lesions, higher numbers of patients in their clinical studies, and monthly and every other month dosing in the first year. Whereas when we look at Izervay, lower numbers, but definitely a difference in safety signal. And we've seen that bear out in the real world. And it's interesting that in my clinic, so many times safety seems to be an issue that patients really come back to. And even though we say it's the low risk, 1 in 4,000 with the first injection, and seemingly if you don't have it happen with retinal vasculitis with the first injection, it's much less likely to occur down the road. Esther, in your experience, does safety move the needle as much?
If there are big screaming risk factors, like patient has OSA that is not controlled, their cup to disc is 0.1, they're obese, I mean, I have made the executive decision. There are some obvious no-brainer cases. I do appreciate that there are on-label uses for Q4 to Q8 dosing with Syfovre. So if a patient has lost a lot of vision due to GA in one eye and then they have their good eye, they're highly motivated. I will dose that patient more frequently, like at Q4 weeks. But it's nice to have that flexibility in dosing. I think at the end of the day, I still do dose both flexibly. That doesn't restrain me really. But I do think that certainly it's nice to have different options available to us. It's always good to have, one option. And I think that will put the pressure on each other to try to come up with an even better solution, to splice and dice the data better so that we can better interpret this in terms of providing the best option for our patients.
I agree. Competition in this field is a really good thing and spurs a lot of great conversation. Miguel, what can we look forward to in the future of GA therapies? What are some things on the horizon?
Yeah, so as we talked about earlier, this is a nascent field, so there are things happening. Right now we're looking at anti-complement 3 and 3B inhibition and C5 with the agents that are currently on the market. There are other agents that are currently being evaluated. One thing that's being studied in the Archer study through Inhibition is an anti-complement C1q agent, which works on the alternative complement pathway. This is an interesting pathway that seems to have downstream effects that appear very beneficial in GA, specifically from the standpoint of photoreceptor and synaptic protection at the cellular level. In fact, some of the phase 2 data from that study did show an improvement on the visual acuity side, or a benefit, I should say, on the visual acuity side, regarding a reduction in loss of vision in the study agent arm, with fewer patients losing 15 or more letters. And that's really the first time that we've seen significant visual acuity benefits from this class of drugs. There's other agents out there. There is a antibody fragment which impacts complement 3 and 3B, and it's a non-pegylated option, which may provide some better safety signals there, and potentially superior efficacy due to a higher molar volume. So these are the types of things that are being played with, both from a functional visual acuity standpoint and then also from a safety and molecular standpoint. So as we talked about with anti-VEGFs and the treatment of wet AMD and exudative disease, we evolved over time with that, and we're starting to see a very similar scientific evolution on the GA side.
That's a great summary, Miguel. Esther, last question is for you. You have a doctor that hasn't yet started GA therapy and is on the fence. What can you tell that doctor to motivate them to consider, utilizing this option for their patients?
I think a lot of providers are reluctant because they kind of view this as like a marriage, like we're going to do this to the end of time. But I'll say this to patients too. Look, we're getting started. We're going to give it a try. We don't need to commit to a lifetime of this. Let's see how it goes, right? So thankfully in my hands, I haven't had any adverse events. I certainly think if you experience something like that early on, yeah, that's going to sensitize you to that. That's human nature. It's recall bias, right? But I think that with this, you really just have to trust the clinical trial data. And I think as retina specialists in general, we're very driven by anatomy. Anatomy is driving our decision making. If you see a recurrence of fluid at the fovea, say in a condition of wet AMD or DME, but the vision didn't necessarily drop by a line, is that going to deter your decision to inject that day? No, I mean, you're definitely going to treat that patient and consider it to be uncontrolled disease. In the same way, I think with GA, the studies are showing that there is a reduction in the size of lesion growth with GA. We know that atrophy is where there's been a loss of photoreceptors and RPE cells. So if you're able to preserve the anatomy, eventually that's going to translate to visual function. I think especially when that gets to reach those central 4 points of fixation or the actual dead foveal center. So I view this as a great starting point, a great bridge to perhaps the next great treatment, sort of how Macugen PDT was a bridge. I gave this analogy to my patient earlier today. We're in sort of a sinking ship, water is pouring in, but we're using buckets to try to get the water out as much as we can, doing what we can, because we know what the inevitable end game is with this condition. It's either that or do nothing and stand by. So it's the patient's, it's a conversation definitely between the provider and the patient. But I would say to give it a try, to get started, and to have confidence in the clinical trial data, which shows that the lesion size is reduced. I think in the long run, which GA is, I think this is going to translate into visual benefit for the patient.
That's a great concluding thought, Esther. Esther, Miguel, I want to thank you for joining us here on New Retina Radio. And I want to ask our listeners to tune in to the second episode of this series on GA options in clinical therapy. We'll have Dr. Saradra Cheksal and Dr. Gita Lawani joining us to try and help us identify the best patients for GA therapy. Thanks again for listening.